you don't know, Dr. Mahul Amin is our editor-in-chief of our 8th edition work, and he's also a senior pathologist. Are you head of pathology at Cedars-Sinai? Chief of pathology at Cedars-Sinai. Thank you very much.
Thank you, David. That's an excellent introduction into what I would like to deliver as an update for the 8th edition. And really, the intent is not only to address the leadership here, the editorial board, but we've been very successful in recording these. And last year, when the plenary sessions were on, some of our volunteers took time to understand what the 8th edition is about. So the message is really, how do we really create and take the 8th edition work and put it into the final product that is vibrant beyond the book manual into an electronic product. Just historically, all of us involved with the 8th edition have the honor and privilege to work on this project, which is 50 years almost in the making, from when the American Joint Commission first formed what was called the Rules and Foundations, and through 7 editions. You can see just last night took a little moment to check the history through this, and to take us to the 8th edition now, which is anticipated for release in 2017. And what I would like to focus is what do we have to get done to deliver this product on time, but not only to deliver it, but to really make it into a product that empowers cancer management and cancer care and cancer research and reporting in the United States and around the world. The philosophy of staging remains the same. There's just one slide just to tie us and remind us with the forefathers, if you will, of AJCC in the first edition. It's very simply and eloquently stated that the intent of this classification is to provide a way by which we can designate a state of cancer at various points of the disease and time, and readily communicate to others and assist in decision-making, and a factor that will help in prognostication. Ultimately, it provides a mechanism for comparing like and unlike groups of cases, particularly in regard to the results of different therapeutic procedures. And this is largely the vision that is part of at the core of the 8th edition. So we have, as we go along, 7 or 8 additional vision points that have helped shape the 8th edition and its product. So a very quick overview of what happened between 2013 and 2014, but in April 2013 is when this entire project really started to take form. I mean, this is an ongoing, there's no real formal start date. It was really in April 2013 that I was brought on, and quickly, with the help of the executive committee, we formed an editorial board that focused on structure. We wanted to make sure that there was a robust structure that enabled the work of 400 to 500 individuals, and to bring that into a very coherent group of individuals that can deliver a complex process and a product. We focus a lot on process, and I'm going to go through today what is required between now and the delivery. A key aspect, and if you really need to get into the electronic era, is really standardization. And so a lot of focus in the first year on standardization. There was a very, I talked about additional vision that this 8th edition had, and that was to take this and to view this edition as a bridge from the traditional population-based approach to a more personalized approach. It cannot be done in one edition, but the journey had to be thoughtfully planned out, and a strategy as to how we will get there was talked about. This is an era of transparency, and where evidence really helps people understand the importance of the changes that we make. And so we've spent quite a bit of time on the culture of evidence-based principles, and importantly, in the first year, figure out a roadmap to take us to the deliverables that Dr. Bird talked about, the electronic health record and point of care sort of application of the 8th edition. So very quickly, in terms of the organization, the reason I want to go into the organizational structure is to focus on the utility of the course that still needs to happen, and that engagement is very important. So we started with the executive committee appointing an editor-in-chief, and we quickly together formed an editorial board. We followed the conventional process that we've had for the last 7 editions, and that is to have these disease site teams here. You can see examples of it, but key was that each disease site team, each disease site expert panel often have disease teams, and to appoint not only a chair and vice chair, but disease team leads. These were very, very carefully vetted out, and one of the important things the editorial board has done is to make this truly multidisciplinary. I emphasize this because in the cores that, in the expert panels that you're involved with, there are several voices beyond surgical oncology, medical oncology, and we want to make sure that all of those are captured in this 8th edition, as it is truly the intent to make this product truly multidisciplinary and effective for all cancer providers. So the key aspect was the formation of the course, and besides an administrative core, we talked about the evidence-based medicine and the precision medicine strategy. We'll talk a little more as an update of the important work that is standardization, and that occurs through content harmonization and data collection cores, and I'll talk a little about how these two have to come together besides the other cores. And one of the reasons why we had the end of yesterday an update from the cores is this is really important, as an important time that all the teams engage with these cores and utilize the expertise. Each of these cores are between 10 and 15 members, and you can see the amount of subject matter expertise that these cores have and how they can empower your disease teams. And finally, the imaging core that actually just started as a group of individuals, which really has taken a very important life of their own, and we'll talk a little about how they have really done some foundational and fundamental work that is important to be incorporated into all these chapters. So here's what the editorial board looks like, and here are the expert panel leadership. Sort of new in the 8th edition is we separated out neuroendocrine. This was a decision in April 2013, and neuroendocrine tumors have 5 or 6 chapters of their own. The GU urologic team as one site was very difficult to handle, so it's been split into kidney and urinary tract and prostate and male genital. And what was previously called foregut and hindgut are now upper and lower GI teams. So truly the emphasis on inclusive and comprehensive, and this is stressed here because we really need the pathology community, the imaging community to actively participate in that chapter writing and to make sure that elements that are important for their constituents to understand are in those chapters. This is not a chapter, we've made the staging changes and let's get the chapter done. This is our opportunity for all these specialties, the oncology team to add comments about neoadjuvant therapy, for the imaging team. So every member of this of these expert panels have to be really actively engaged in the chapter writing. And of course, we've broadened the leadership in AJCC, and that's obviously vital and has brought in fresh thought and expertise into this process. Now, as Dr. Bird has mentioned, there's an editorial board that meets at least on the telephone once a month. We have hundreds of emails, if not adding to probably almost 1,000 in terms of what has been done over the years. And we've talked about the cores that have been built in. Now, an important aspect, and I stress this because this is key to that standardization component, and that the editorial board developed this standard chapter outline that has been mentioned. And it is very important for all the expert panels and the teams to author within this standardized chapter template. We've also, as I said, have talked about the approach for personalized medicine and evidence-based medicine course, but also the general staging rules are very important for the standardization effort of the 8th edition. So in those 8 high-level vision statements that we mentioned, really the key is that if the 8th edition remains as a definitive, comprehensive, proactive, evidence-based, clinically relevant taxonomy of human malignancy, we need to retain the very foundation of the basis of anatomic stage, but to incorporate molecular biomarkers and other strategies to make a more accurate disease stratification. And so this we've done through the precision medicine course. So a few words about how the precision medicine course still needs to be engaged in these last 3 months. This was to help us personalize the take this population-based stratification effort into a more personalized one. And there are 2 strategies. One is that the precision medicine core would help evaluate in 7 sites, and they are listed here: breast, melanoma, colon, prostate, lung, head and neck, and soft tissue sarcoma. And I see some of the soft tissue leadership here, to assess risk assessment models and to bring them as AJCC approved risk assessment models that could be incorporated as part of the 8th edition product. And through the year that we've been working on it, the team has developed this chart that helps people understand how we intend to cross this bridge and build this bridge between population-based and personalized approaches. Towards this, I have to thank Dr. Compton and her leadership. Dr. Compton actually was instrumental in finding funds for a face-to-face meeting. And this face-to-face meeting, the personalized medicine core came up with inclusion and exclusion criteria that Dr. Compton had briefly alluded to yesterday. These will set the standards not only for the 8th edition, but for years to come, as we have more and more risk assessment models, as to what would be those minimal standards by which the data will be evaluated and which will be then meeting the high bar that AJCC needs in order to approve a risk assessment model. And so to build on that transition, we will, of course, use the first aspect, that is the TNM, the anatomic as the classification, as the basic classification. We're building the prognostic factors. And then as this effort continues, and this is happening already in the 8th edition, is to bring in not only the prognostic factors, but risk assessment models. And an important additional aspect, that's an important part of the chapters, and that is a section on clinical trial stratification and what elements should be required if new clinical trials need to be formulated. And so here is really the vision of taking, as you see on the left side, the cancer stage, which has been really the focus of the AJCC, into a much more comprehensive cancer profile. And that profile would be done through these layers of information that the 8th edition and future editions would provide. A few words about the prognostic factors, because this is very important, is that the prognostic factors in the 8th edition and going forward are classified into 3 categories. Prognostic factors required for staging. It could be Gleason score, PSA, serum levels of certain biomarkers. Prognostic factors required for clinical care. So they are beyond those for staging, and we need the chapters to clearly outline those, and other factors required for clinical care. And it's important that in each of the prognostic factors, those required for staging are self-explanatory. Those that are recommended for clinical care, they describe factors that are not required for staging, but there is sufficient evidence, and we need to provide that levels of evidence to the community so that we are transparent as to why those factors are important for clinical care and help standardize the prognostication of those cancers. And we believe that these prognostic factors for clinical care will be captured by standard setters. The other factors for clinical care are those factors that are recognized by experts that have promise but currently lack the level of evidence, and we need to bring in those because this is a work in process, and we want to show that we are not only thinking about today's care but also what is likely to emerge or is emerging in the field as significant. These are not required for collection. They're pending validation, and hopefully will stimulate research as to their true place in clinical management. The factors required for clinical trial stratification, again, if one looks at the template, this is all well laid out there. The introduction that I'm giving you here about clinical trials, stratification, what goes into that section is also in the chapter template. And this is, again, as I said, it's a new sort of heading into the 8th edition. And our vision is to allow disease site teams and experts to identify those important prognostic factors. And these should optimally include consistently accepted standardized factors so that they can be compared across trials or with known standards of management. The risk assessment models that we talked about, at least on the 7 sites, the work began early this year by the face-to-face meeting that I mentioned. I've talked about the 6 or 7 sites that are important, and so if you're one of the leadership of those 7 sites and still not completely engaged, and I know that that work is ongoing now, this is a critical time, please reach out to Dr. Compton and their team. They have an amazing group of biostatisticians, computational biologists, modelers, and just people who are interested in risk assessment. The evidence-based medicine core, again, why this is an important aspect, and while the teams have really focused on what needs to be changed, we need to now focus on making sure that the levels of evidence have been examined and are reported through the 8th edition. And Dr. Hess mentioned that our approach, and really thank him for the leadership there, the approach is that we have a system that's relatively simple and yet explains where we are and how those changes that we are proposing in this 8th edition, the new prognostic factors, have come about. And these are the 4 levels of evidence. They're abbreviated here, but again on the website we have much more detailed information. And I still would like to urge the chairs, because they're aware of this levels of evidence, but really how they flow to the process needs to be incorporated into the thinking and the delivery of the final chapter. And the entire evidence-based medicine team is available to you. Each of the members of the evidence-based medicine team is part of those disease site teams. So please make sure that that engagement occurs. So these are just overarching principles of levels of evidence, and I'll skip past that aspect. Key has been content harmonization as part of the standardization process, and this core, the content harmonization core, was empowered to clarify and resolve inconsistencies in the staging rules and their application. And as we started yesterday, the key is that there should be clarity and accuracy and minimizing ambiguity, getting rid of some of the old concepts and introducing new concepts. And that was certainly the focus of yesterday. Through 4 phases over 2 years, we've come to a year and a half. We had the summit yesterday. This was truly a very exhaustive and comprehensive formal review of all the general staging rules. And while this has been done in all the editions in the past to some extent, it has never been done in such a comprehensive fashion. And we were really thankful to all of you who were here yesterday. Approximately 50 participants. We had 5 hours of important discussion, 198 slides in which we covered most important issues that were vast and diverse. The issues of general staging rules at the end of the day are really 38. I mean, those that need our attention are 38 basic conceptual issues that involve classification, the T, N, and M categories, and the stage groups. And one of the things that we came away with is the appreciation that the general staging rule application is incredibly complex and consists of multiple nuances. And also some of the comments I heard is how many of the physician leaderships themselves were not aware of some of the complexities here and how they need to be engaged going forward in the process of applying these general staging rules and in staging. And so as a next step, and this is a higher level overview at the end of my talk, Dr. Gershenwald will also make some comments. But we, as a team with Dr. Bird and Dr. Gershenwald and Laura and Marty, sat until late yesterday evening, almost 7:30, to kind of wrap up what we learned through the day. And our high-level summary as to where we are going with what we learned yesterday would be summarized as the following. All the discussion that we took that takes place and the general staging rules, we're going to divide into these following categories. Of course, these are just made late last night, so these are just thoughts in evolution, but we feel quite strongly that we will have to accomplish this for the 8th edition and going forward. So, of course, there are general staging rules that require no change, so they will be included in the 8th edition. There were general staging rules that changes were made based upon yesterday's discussion. There were clear consensus, and so those will be included in the 8th edition. There are other critical general staging rules that we had good discussion, but we need to have much more input from subject matter experts. And so we are drafting out a plan to outline those important issues that need to be included in the 8th edition, and we're going to work on that between now and January and how this will get incorporated into the chapters. For general staging rules for which data and consensus don't exist, and now I hope you all have a flavor that there are many of those, we're going to acknowledge that we will have some recommendations, but work is in progress for future editions. But most importantly, we realize that while general staging rules are general guidelines, there are some specific applications for disease sites. And so we want to understand, we've understood, and we want to portray in that first chapter that there are disease site-specific rules that do not assign to general staging rules. And as much as we can understand and capture them, we want to identify them and acknowledge them in the first edition. So that's really a sort of overview approach to what we learned from yesterday. The involvement of the radiology community, the imaging community, is just staggering and mind-blowing. And so but the few comments that I'll make are just, they don't even underscore the amount of work and the impact that the imaging community has brought to the 8th edition. And we have to thank Dr. Dan Sullivan for his leadership there. And he's assembled 24 really dedicated members of the imaging community. And each of these are now representative on the expert panels. They emphasize the important role of imaging in clinical staging. And as was mentioned yesterday, Dr. Glastonbury is already authored a paper, Do Radiologists Have Stage Fright, and really encouraging synoptic reporting in radiology. Now, very important for the 8th edition is that this team of 24 individuals has guidelines or almost a standardized approach in each chapter. So each of the chapters and each of the diseases will have an imaging section. And that imaging section will describe imaging in 3 sort of broad concepts. First, they'll describe imaging tests appropriate for that specific disease as to what they think is appropriate for cancer staging. They will describe the T, N, and M information that could be extracted from those imaging tests for specific disease and suggest a structured reporting, and that's the pathway to synoptic reporting. And also in keeping with the evolution into future editions and formats, describe emerging imaging methods that may be used in some specialized centers or are becoming increasingly used in clinical practice. We want to encourage the use of onstage. The only reason I meant to show this slide is the editorial board and the staff have spent considerable time in an authoring manual. So it's like your go-to book. When you have any issue, of course, Laura and her staff are always available, but if you need this authoring manual is on what we one or two slides got blocked off, but is on stage. What do we call this? On stage exchange, and maybe the stage exchange slides will come in just a minute. Now, an additional aspect that is very important for the 8th edition for the leadership to understand is that the work beyond the 8th edition and the electronic health record is into information gathering for the registrar community. And it's very important to capture all this information for that registrar community that goes into the data collection process. So the primary aim of what's called DERF, or the Data Element Review Form, and I'm going to tell you, I'm going to simplify it for you because don't get overwhelmed by this concept, but we've really got a pathway to make this simple, but we need you to understand it's a very important place as an 8th edition derivative. We need to collect, the aim is to collect information to support the new data elements and changes that have been made. So we want to identify, here are the changes, here are the prognostic factors, here are the levels of evidence and why it is important for standard of care. So that's that listing. And then with each of those DERFs, we need, for example, based on a certain prognostic factor or test, whether the first value is important, the last value is important, whether it's a negative test, positive test, and so that needs to be captured. And also, we need to guide the data collection community as to where this information will be. Do you collect it from the clinical information or from the lab reports, imaging, etc.? So the aim is to have that very summarized information for this community. And so this information will be collected from the chapter template. Now, again, it is not the primary responsibility of the disease site teams to generate this data, the DERF. But we have staff who will work with you after your chapter is submitted and make sure that all the elements of data element review form are collected first. They'll make a synopsis of it, and they'll send it back to your review. And if you need the evidence-based medicine core for the levels of evidence and how you need to mention them, they are available. So there was some, I'm spending a few minutes here on this because there was some level of confusion as to DERF. It became an overwhelming, here's one more process. And our job here is to make sure that the staff here and the data collection core and the content harmonization core are all available as resources to make and simplify this process. And so just to give you an idea, the importance of this data collection core, and this is sort of the flow chart, is to complete the, we want the expert panels to complete their work. The DERF information is then entered into the database that goes, as you can see below, for registrar education. A summary of the data elements is created and is sent to the standard setters so that they can incorporate their integration into their data collection elements. Stage exchange. So the importance of showing this slide is that there are several groups that are still working through email, and the Word documents are going through without version control. And I know one site that has 17 different reviews and track changing, and really the team tends to lose version control. Stage exchange is incredibly powerful. It may sound daunting at first, and I know most of you have used it, but I do really encourage the use of stage exchange because it allows the staff to monitor progress and really allows sharing of data and version control at this very important time, and it helps continue to build that collaborative environment. The way we've tracked changes is through this dashboard. We've sent this out to the entire community of the individuals involved with the with staging, and helps us understand if the teams are on track and which team needs to continue to speed up. Now, so what is happening? What happened sort of as an overview of between last year and October 15 or right now. All the teams have been, we had the launch, that's illustrated here. There's a literature review going that went on, deliberations, staging recommendations, and almost all teams, there are 2 or 3 that are in those final phases, have finished those first 3. Several teams have started chapter writing, and the intention is that we expect most teams to deliver their chapters by the October 31st deadline, and simultaneously the editorial review process will complete. So now I'm going to spend a few minutes on what will happen as soon as these chapters are completed. Now, just a quick update is in these deliberations of 8th edition, besides all the changes we've made, I wanted to give you some high-level overview of what are the important things that are going on. There are numerous teams that are discussing definitional changes, and this is based on NCDB SEER data, and they're using numerous large international databases, ISLC database on esophageal cancer, gastric cancer, and several others. There are new paradigms being brought through. For example, in oropharyngeal cancer, there's going to be a chapter on HPV-related and a stage in which the HPV status is the first entry to whether a patient gets stratified into a certain staging system. We'll have a new staging system for thymoma. In esophagus, the team is considering separating the adeno and squamous into separate staging systems or potentially even to separate chapters. And that for the first time, we will have in esophagus a C stage, a P stage, and because of several patients undergoing neoadjuvant therapy, a YP stage, because the stratification of patients in these categories are considerably different. The GI and oncology team is working with FIGO and new proposals in cancers, including leiomyosarcoma. The bone and soft tissue team is thinking about further stratifying the staging, first based on where the tumor is, whether the skull or in long bones. You might have heard last year we gave you an update about squamous cell carcinoma. The cutaneous squamous cell carcinoma section is dropped, but the squamous cell carcinoma, where it's clinically significant in head and neck and anal cancers, are now being taken out into those disease sites. In soft tissue sarcoma, again, thinking about sarcoma staging based on where the tumor is, whether it's in the head and neck, GI stromal sarcoma, retroperitoneal. So rather than a one-size-fits-all staging system, and including based on histologies, are sort of new staging paradigms that the soft tissue sarcoma has come up with. And I just wanted to give you a flavor of some of the important things that the work of all these great volunteers is yielding in terms of 8th edition. So when you have a chapter that's completed, just like when you submit a manuscript, there is a submission checklist. And our submission checklist is a little overwhelming at first, but really the aim is to capture the following. We want to make sure that when you submit a chapter, the format is adhered to. We want to make sure that all the things that we would like in a chapter are there, because we want to standardize chapters. We want to take it to that electronic format. We want to make sure that if you need copyright, if you are using copyright edition material, you give us advance notice. The staff can get the copyright permission for you, and the staff will get that for you. We want to make sure all the appropriate authorship is recognized. And this is an important commitment the 8th edition editorial board made, that all the volunteers are giving their time, and we're going to not only acknowledge their contributions, like in the past, not at the back of the book, but somewhere where it is really recognized for academic credibility and recognition of the work. And an important aspect is this form will also tell us which illustrations need to be included and modified as we go forward. Now, once your chapters are submitted, the chapters will go to an editorial board for review. And the review will be primarily done by your editorial board liaisons. As you all know, the editorial board, the 17 members, each of them have a site or two or sometimes three, depending on the editorial board members, because some are in charge of 4. They work with those expert panels, and that editorial board liaison is the primary subject matter expert reviewer. The liaison will use that guideline to check format and content, will review the major changes, and they will present these to the editorial board that will approve it. So just sort of as to how this process is once you complete it. This process is to make sure that all the steps are followed. We're not going to add additional hurdles and blocks, but we want to make sure that this level of additional supervision oversight is provided for this process. So 9/14, here's where we are. We will distribute next week, so we're on 9/11 today. Next Friday, we'll submit the checklist, chapter checklist distribution. So all the chairs and vice chairs in the disease teams will have that chapter submission list so that they know what is required to submit a chapter. By 10/31, as we said, we expect most chapters to be completed. A few that are waiting for face-to-face meetings because of data that's been collected will submit by 12/31. But during that time, all these chapters will be reviewed by the liaison, and some of the major changes will be presented to the editorial board. The manuscripts may be sent back for revisions, but between 12/31 and March of next year, we expect that not only will all manuscripts be submitted, reviewed, revised, but also copy edited for the conversions. And so the conversions, Dr. Bird has already talked about it, our vision that there will be this interoperable data that will enhance the 8th edition to an electronic product. And so I'm just going to basically go into what the two components are that are required beyond the authoring. The two words you will hear, CMS, or Content Management System, and API. And so for harmonization across all chapters and to facilitate standard incorporation into electronic health records and other publications, there are three principles that are important. That there's use, utility, and maintainability of all the content that is generated now and then can be revised in future years. And so Dr. Winchester will talk about where we are with the, who's going to be latest in the appraisal of the vendors that provide this. But that content management system, and you see that sort of central computer type icon here, will help as a single source that will help in the staging manual, those electronic products, sub-staging manuals, things that will be used for the UICC, collaboration for ASCO, and many other deliverables that are sort of derivatives of the 8th edition product and NCCN guidelines, etc. So it's really important that everybody understands that there's a lot of time and commitment and work beyond the scenes. So this is not something that the teams have to be worried about, but there's been a tremendous, as much as the effort in setting these 8th edition changes has gone behind the scenes in this content management system. And as Dr. Bird has illustrated, we, the authors, have to focus on the expert panel, the expert panel deliberations and writing in the Word format. And then behind the scenes, this is the work that the staff will do, will be this content management system, and the other word that we would like you to just at least be aware of, that's the content management system. And then there will be this application programming interface that truly allows to take this content and convert it into the deliverables that we've talked about. So the steps after chapter submission is the Ed Board liaison review, the Ed Board approval, the copy editing, pre-processing for XML conversion, XML conversion, proof outputs, API testing and development. And we may be reaching out to you when some of these steps are done, if there is some sort of reconfiguring of your chapter that needs to be done. So our milestones, just so that you understand what's going to happen beyond January, between January and June, the focus will be on conversion to XML, and as these things get converted to XML into that CMS to start the API programming testing. And then finally, to test and proofread all this stuff between now or January until August. So we have a plan between now to June and June to August to finally deliver these issues. It is anticipated that all this work will ultimately transform into the information that is important for the book and the electronic conversion by October 2016. And we are hoping that this will now then be available to the community for adoption to clinical practice in 2017. I wanted to just end with the last 2 or 3 slides. Dr. Bird has already talked about this, but it was important that, several, and just when we started this work, it was a little black box to people as to how these AJCC changes came about, and who's doing this and how is this done. So we thought we'd capture some of this information as a sort of means to be transparent to the cancer community and the patients as to what really goes beyond. And so see, these are some of the numbers. We have 25 committees, and you can see those committees there. We have made sure that all cancer-related stakeholders are represented. There are 88 subcommittees and disease site teams. There are 500 total seats that are of individuals who are required for all these committees and chapters, and there are 422 individuals who fulfill those seats. There are 188 institutions around the world from 23 countries and 5 continents that are represented here. So this is truly not only an effort of a few individuals from a few academic centers, from a few specialties, but truly a comprehensive worldwide effort. And if one looks at the specialties, surgical oncology, pathology, medical oncology, radiation oncology, imaging, the registrar community, they're all represented. And there's a very good distribution based on the relative sort of amount of work and the contributions we need from these specialties. Dr. Bird talked about literally the thousands of hours, and this was 6 combined volunteer work. But I like to add that these are only the recorded hours and do not take into account the discretionary work. I mean, there's hours in writing a chapter, hours in reviewing papers, email exchanges that is not even captured. So this is just an amazing amount of human effort that's gone into on this product. So to ensure the continued success, the last quarter of 2015 will be the most significant for the expert panel, leadership, and editorial board to complete the authoring in the format that we are proposing. And it seems a little more stringent than it is because we want a standardized product. And this is really that transition that we hope that will pave the way for many, many future editions in a much more simple fashion. So this effort is truly important, is foundational for the next phase of where the AJCC will be. And the first quarter of 2016 will be where the staff will be very active with the editorial board in the content transformation and API delivery. So I wanted to end by